Good morning. I'm Dr. Jose Wiley, and welcome to peripheral.interventions.org in partnership with the American College of Cardiology. Today is October 23rd, 8:04 a.m. Eastern Standard Time. We're broadcasting live from Mount Sinai Medical Center in our 22nd session. You will be able to post your questions online at info@peripheral.interventions.org, info@peripheral.interventions.org. I will turn the audio to Dr. Krishnan for an interesting and challenging case, but before, Dr. Krishnan will pick up on our last month live case and move forward after. Dr. Krishnan?
Good morning, Dr. Wiley. Good morning, everyone. Thank you so much for joining us again. I'm pretty excited that it's our 22nd live case, as Dr. Wiley just said. Before we get started, last month, for those of you who are with us and have seen the archive cases, you know that we could not finish because we did not have the right size stent, which can occur at any lab, and it did occur in our lab at that time. So I want to go back, as I promised you, and recap what we did to handle that. It took us probably another 30 minutes to get the stent from our inventory area, and then we went ahead and did it from another part of the hospital. So let me show you exactly what we've done here. So you can see, if you show the camera, so this was the case with the deep vein thrombosis and the iliac vein thrombosis, and you can see here you after balloon angioplasty of the common femoral or external iliac vein, you still had a filling defect. At that time, Dr. Malik, myself, Dr. Wiley decided to go ahead and place a stent. So I'm just showing you the different views of this to show you how much fibrosis and recoil there actually was on this particular patient. So we went ahead and put I believe it was a 60 wall stent, and you can see here, even after placing that stent, you have quite a bit of recoil. So then we went ahead and did high pressure balloon angioplasty with a high pressure non-compliant balloon, and you could see as multiple different inflations are occurring. But and then you could see that finally at this stage we went ahead and were able to reasonably expand that particular stent. Now, I want you to note two things. One, I want you to note how the stent expanded, and how it's so important to remember that the vein can actually expand after you open up a stenosis, and that's why picking a stent that's large enough is extremely, extremely important. And obviously, this stent was extremely large and actually worked out.
Prakash, let me interrupt you. What size is that stent?
I believe it's an 18. I said it was a 16, Jose. I believe it's an 18-060 wall stent.
Okay.
I'm sorry, it was an 18-060. Dr. Guja just corrected me. An 18-060 wall stent. And I think, remember, we were talking about whether or not we should put a 14 millimeter stent or not, regular self-expanding. You can also see the level of fibrosis here. I don't know how it's showing up to you guys, but you can see that even though we expanded with a 12 or 13 or even 14 millimeter balloon, you can see that there's quite a bit of recoil. So it's extremely important for you to have a stent that has the radial strength for us to expand. So then you can see here, when we inject, finally, you've got wonderful flow, you've got clear reduction of your stenosis, although the filling defect remains, and the hope is that this will continue to expand. It's 1-to-1 sized here. Over here you can see there's a little bit of drop off. But obviously we've been following her clinically. Here's with a larger balloon. I believe this was a 14-0 balloon. And then you can see here, after that balloon, even after that balloon, there's not much resolution of the stenosis at all, other than the fact that we were able to get great flow.
So you reduced probably 60% of the
I would
lesion,
say probably even more, maybe even 70 or 80% here, Dr. Wiley. As you can see here, it's probably around 70% reduction of the stenosis. But the interesting thing and the good thing was that she has complete resolution of her symptoms. The edema is completely gone. Obviously, we're doing everything we talked about last month, including Job's or compression stockings, and obviously we're following her closely to make sure that everything is well. Antiplatelet therapy, she's on dual antiplatelet therapy at this time, and we have actually removed the IVC filter as well that we had put in prophylactically. So I can tell you that overall she's doing really, really well. And I just wanted to show you guys all the points that we talked about and the final result of our case last week.
Excellent.
Great. So I'm going to kick it over to Dr. Guja to start the presentation while I get dressed to go into this interesting case. So as you guys know, my team is Dr. Karthik Guja, who's our endovascular structural fellow here at Mount Sinai, Dr. Ray Lascano, our interventional nurse practitioner. We've got Dr. Surabhi, our fellow. We've got Ricardo, our technician, and we've got Elizabeth Holton, our vascular nurse. So Karthik.
Thank you, Dr. Krishnan. Good morning, everyone, at least here on the East Coast. To present the brief history on the patient, we have here today an interesting case of critical limb ischemia. So a patient came with chief complaints of left leg or foot pain with partially healing ulcer along the dorsal surface of the foot. The history presenting illness of the patient was 78-year-old male patient with complaints of resting left leg pain with a small partially healing ulcer along the dorsal surface of the foot. Patient by Rutherford classification is class 3 category 5, and Fontaine classification it's a 4. Patient has a history of hypertension, dyslipidemia, CAD status was cabbage. He's CKD stage 3, diabetes type 2. He has a CVA in the past, and he has mal-determined asthma. He's on Lantus, aspirin, Lasix, Coreg, Imdor, fenofibrate, Pleatel for a long time for his claudication until he developed ulcer in the foot. And Spiriva. Patient is an ex-smoker, 30 pack is just smoking, quit 3 years ago with no alcohol or IV drug use. Next slide, please. Pertinent physical findings are physical exam are basically patient having Doppler pulses, only PT being Dopplerable, and then he has a partially healing ulcer on the dorsal surface of the foot with granulation tissue and punched out edges, typical of an arterial ulcer with no significant erythema around it. Patient has been on antibiotic therapy for about 4 weeks prior to his initial peripheral angiogram. Next slide, please. Patient had an ABI PVR done about a couple of months ago, which showed non-compressible vessels, but TBI bilaterally of 1.4. Patient had PVR with significantly dampened waveforms, suggestive of moderate SFA stenosis and severe below-knee disease. We performed a peripheral angiogram a week ago, which showed 60 to 70% stenosis of the mid-left superficial femoral artery and CTO of the mid left anterior tibial artery and a CTO of the left tibioperoneal trunk, which has distal reconstitution of both peroneal and the posterior tibial artery are via the proximal anterior tibial collaterals. But the DP again reconstitutes distally faintly via the peroneal artery collaterals. So based on the patient having an ulcer and a resting leg pain, we plan to do endovascular intervention of the CTO of the left tibioperoneal trunk, classifying him as a critical limb ischemia.
Dr. Guja, let me interrupt you. So there's no straight line flow to the area of ulceration, correct?
That's right. That's right.
So Dr. Wiley, I think this is a very, very interesting patient, and I think we should really get into it. I think it really reflects the scope of diabetic foot disease, and also patients who have this renal insufficiency. So here's a gentleman who obviously has critical limb ischemia with rest pain. I'm just going to go with the fielder here, and I think what I want to do is illustrate first of all angiographically what are the things we're having. Can you go to the first scene, please? So obviously I want to just discuss the angiogram before we get started. So you can see here that this is the SFA. Obviously there's no iliac disease. He has some moderate SFA stenosis, maybe a little bit of a filling defect there. We know it's not acute. We don't think it's thrombotic. So there is a little bit of a filling defect at that spot that we're going to have to take care of. Next, please. So when you come down to below the knee, you can see that this is the trifurcation. At the level of the trifurcation, you can see that the popliteal artery comes down. You've got an anterior tibial artery that's occluded, reconstituting by a nice collateral, which the anterior tibial artery reconstitutes and collateralizes the peroneal artery. And then you also have another vessel, which is unnamed, that goes and reconstitutes the posterior tibial artery, which is to the left of your screen. Next, please. So then, as you come down further down on your tibials, you can see here that on this view, again, you're pretty much illustrating what we talked about. Next, please. Now you want to go to the level of the foot. Now this is not quite the level of the foot yet. I know they did take a foot shot. So here's a foot shot here. You can see that your only real straight line flow is through the posterior tibial artery, and you can see that the posterior tibial artery and the perineal artery collateralize the anterior tibial artery. The most robust flow you're getting here is through the posterior tibial artery into the foot, and you can see that the arch is actually forming. Good. So I think it's important to talk about the approach to this patient. Obviously, he's had this chronic non-healing situation, and because of that, I mean, ideally speaking, since the ulcer is located over the dorsum of the foot, ideally speaking, it would probably be ideal to fix the anterior tibial artery. At this stage, however, since we're planning on staging him and we'd like to stabilize this situation from getting worse, what we decided to do was to increase get at least one straight line flow into the foot, and obviously deal with both the inflow as well as the outflow at the same time. So it's important for those of you out there who are getting started in below knee intervention to first of all understand the anatomy and understand what you're looking at angiographically. So now if you can go scene plus, please. So one of the techniques, actually minus then, one of the techniques that we've started to do is actually to look at multiple views, which I think is extremely important, of the posterior tibial, anterior tibial, as well as the trifurcation. So you can see here as they go back to the trifurcation, we did two different views. One is an RAO view and one is an LAO view. And the RAO view is typically not the view we normally teach when we'd like to look at the circulation below the knee. But you can see in the RAO view here, you kind of can see a little bit of a subtotal to totally occluded channel, leading right to the posterior tibial. But however, if you look at this at the LAO view, which is right here, you're completely overlapped by collaterals. Why didn't you stay there? That was what I wanted to show. The LAO view. So the LAO view here, you can see here that when you see it in the LAO view, you clearly see that you only see an anterior tibial artery. You can't really see any straight channel into the posterior tibial artery. However, when you go back to the RAO view, which is the next view, or the view before this, whichever they decided to do, you can see clearly now that you do have possibly what's a channel. Now, what's important to remember is your equipment and your approach. Now, there's three different ways we can approach this particular thing. Now, anytime you're dealing with a below lesion, your options are very simple. You can go up and over, as we've chosen to do here, which is a contralateral access with an up and over sheath. Number two, you can do antegrade puncture going all the way down into the posterior tibial or to the below knee vessels, or you can do pedal access so you can come back up. Okay, so you have multiple different views on multiple different approaches that you need to do, and based on I'm going to talk to you about our algorithm of doing one or the other. Majority of our work here at Sinai is done over the up and over approach, although the antegrade approach is very good if you have a difficulty in terms of a tortuous iliac, as well as if you have difficulty in terms of torquing the wire or getting your devices to reach down all the way to the foot in terms of if you have a very tall patient. So generally, most of the time we go with an up and over approach, which is what we've done. Number two is as far as your pedal access is concerned, we generally reserve pedal access is to when we have failed an up and over or an antegrade approach. We feel that obviously those are the vessels that are supplying the tissue at risk, so therefore we don't want to be able to obviously disrupt those vessels even with as atraumatically as we do it with a sheathless approach and a 018 quick cross approach.
So are you ready to access the pedal access if needed?
Yes. So what we did was we went ahead. I'm anticipating we won't need it, Dr. Wiley, but I don't know. Anything can happen. So we've actually had our lead technician Ricky to go ahead and prepare the pedal vessels for us to access.
This is going to be a complex case. I'm not seeing any channel that you're seeing. I think it's CTO of the three infrapalpatile vessels.
Well, I think you're right, and I think what we're going to do is we're going to get down there, and I'm going to backload this with an 018 Trailblazer, and then we're going to go. So as far as equipment to use, I think it's important to remember that what you want to do is go ahead and get into coronary style equipment. Mag up, please, at the proximal. Coronary style equipment. There it comes. There's the wire.
Because do you ever use a multi-purpose catheter for some support?
I know you're a big fan of that, Dr. Wiley. We have never, myself and Ray Lascano have never done that. I know that there are different techniques, like you said, of us to do it. So give me an 018 to support catheter, please. So what we usually do is, that's an 014, I want an 018. With 018, so what we normally do is go ahead and go with a 014 catheter and 018 014 wire and an 018 catheter.
Okay, so that'll give you the support you need.
Well, I think the reason you do it is for visualization. I think the visualization is clearly a lot better if you have I guess a diagnostic guide at the level of your popliteal artery. I think there are multiple different ways of working, but I just find that very cumbersome. And so here, we're going to go ahead and do it this way. And we have a very cooperative patient, so we should be able to get through quite easily.
Prakash, what anticoagulation are you using?
So we're currently using bivalrudin mag up, guys. Don't let this wire go down, please. We're currently using bivalrudin. And what we're going to do here is get very close. And then I'm going to have Dr. Guja mag up even more.
What size sheath are you using?
We're using a 6-French sheath, Dr. Wiley.
Okay.
So we're going to get very close, as you can see. Okay. So what we're going to do at this stage is just try to get this wire down to the post, into the cap, which is right there. Now I'm going to have Dr. Guja mag up, show me a little lower.
By the way, to the audience, I'd like to re-emphasize that you can post your questions
roadmap, please.
info@peripheраlinterventions.org, info@peripheраlinterventions.org, and I will relay those questions to Dr. Krishnan.
So you can see here we've injected from above with the catheter at the level of the cap, and you can see that his flow is not the best, but you can start to see there's some form of collateralization that's occurring there, and I think I'm actually already in the right channel.
So you want to access what vessel?
Well, I'd like to get into the posterior tibial, Dr. Wiley.
Okay.
So now what I want to do is I want to ask the guys to go scene minus. I want to go to that RAO shot of the posterior tibial, gentlemen. The magnified view, yeah. So you can see this is very important for us to look at this in multiple different views. So you can see in the RAO shot in the posterior tibial, you get a formation of what looks like a TPT into what looks like a posterior tibial. I seem to think that I'm in that same area here. So now what I'm going to do is stop, and I'm going to come off road map, right? Okay, I'm going to go to the same view, and I think this is important for those of you who are starting out to use the similar views to be able to see what's going on. So now I'm going to go ahead and come off road map, and I'm going to center my table, okay? And now I'm going to do a DSA picture again at this view. Stay at the same view, guys. That's the key. Okay, now we're going to do a DSA of the same view. Ready? Okay, inject, gentlemen. So I'm going to wait a little bit before I step on cine. So now you can see the dye is coming, right? So you can see it's such an occlusive little thing that my wire itself has occluded that vessel. But in general, it looks pretty promising that I'm heading in the right direction if you compare it to the other view. So now you see the posterior tibial reconstituting, right? So now you'll see in the last view, but if you can show both screens, can you show both screens, gentlemen? Can you show the still screen? Right now you're showing the live screen. Show the still screen, which is the next one. Maybe you can do it on the camera. So you can see if you compare the live and the still, okay? There you go. When you compare the live and the still, you can see that the wire is almost heading into that branch that we want to get into, which I believe is the posterior tibial. So now at this stage, I'm going to go back live, and I'm going to be very, very gentle.
Prakash, what wire are you using?
I'm using a fielder wire, Dr. Wiley.
Okay.
I'm using a fielder wire. So I'm just going to try to see whether this goes. And at certain stages, you're going to have to go with the support catheter a little bit lower. But right now, I'm just trying to get a feel for where we are. So I'm just going to try to bring the support catheter a little bit lower here. Hold on, I'm just going to hold this. I got it. Mm-hmm. So sometimes with this kind of situation, you need to have more than two hands. So we're just going to go ahead and not push that. and then see whether we can get it through. You can see it's moving quite freely. So then the other thing we can do, Dr. Wiley, is take this down, and I want to teach everybody the different tricks that we use, right? And then inject through this catheter. So give me some diagrams.
It's going to be a tricky case.
It is a tricky case. That's why I'm being
If you're in that collateral, you're going to perforate. So.
Well, I mean, one of the things I guess you have to make sure that you're not in that collateral, but I think we'll never know, will we? So until we're in there. So we're going to take a little shot here. You see that, Dr. Wiley? You see how much it showed us? So now I'm certain I'm not in that collateral. Now I'm going to ask Dr. Guja to go on roadmap now. So this is what I want the audience to understand, which is this angiographic, sometimes what we call as angiographic lies. You know, roadmap, please. So when you see it like this, what happens is you tend to get more confident after you get down there and take a better picture, but it's important for you to analyze. Give me a confianza here, guys. It's important for you to analyze. Actually, give me the field. The fielder was going fine. It's important for you to analyze. So as far as the wires that you use are also extremely important. So the choices of wires for below the knee range from 018 wires to 014 wires, and I think it all depends on the experience level of the operator. We as such really follow a typical coronary style technique in doing this kind of work. So the coronary style technique is, you know, we go ahead with 014 wires, and then we go ahead and start and upgrade our wires slowly. Generally, we do not. We start with a hydrophilic type wire when we feel we have these sort of very, very simple or not simple, very, very small collaterals or small channels to get through. So that's going to be our plan right now. So what we're doing is we're going with a hydrophilic, extremely steerable coronary wire. One second, I just got to push this forward. Hydrophilic, extremely steerable coronary wire to be able to guide my 018 support catheter. Now you may ask me, well, why did I use an 018 support catheter, right? Well, I use an 018 support catheter here because I really believe that this is going to actually may need an 018 wire if we're not able to get through. So you can see here how slippery the 018 support catheter is and how nicely it helps and really is going down nicely. Now you can understand at this level, you know, you might be uncomfortable with perforation, this, that, the other thing. So I am going to actually now try to I'm going to pull this wire back and try to just wiggle it through with a little bit of, you know, elbow grease, as they say. And I can see I'm getting stuck somewhere there. So what we're going to do now is we're going to come off this, go to another view. Actually, stay in this view. Come back down lower. Now, we're doing this for teaching, Dr. Wiley, and I want you to be aware of that. So I want to go ahead and do DSA here.
So it should be in the posterior tibialis.
Probably not quite. I think there's a second occlusion there. Inject. So we've injected now, and you can see that the collaterals are filling. Looking for the retrograde channel, which is right there, which is coming there, and I'm probably at that second level CTO. You see that, Dr. Wiley?
Yep, I see
Now, I may be getting into some other channel or not. I'm not certain. So what I'm going to do here is now I'm going to switch out for a stiffer wire because this wire doesn't seem to be giving me any support. Show me a little higher, guys. Okay, so I'm going to pull this wire back. See, it's just hitting that blunt stump.
Are you going to continue with the 018 support catheter? Or
I'm finding that the support catheter is really helping me here, Dr. Wiley. So I'm not going to switch to an 014 yet unless I'm not able to do it. Now this is the Now, just to be a little bit overkill and to demonstrate even a little further, I'm going to inject into this collateral, this small little collateral, to see where we are to even be more confident. So you can see there, you have a small little channel into that posterior tibial artery. Now, don't get fooled. Remember there was a collateral that came down below, so I want to go down a little lower, right? I want to go down a little bit lower. So I'm going to have Dr. Guja just help me a little bit here. So leave it right there. And I'm going to inject again, because you might still be in a collateral going into another collateral. So let's see. So see, so you are in a collateral, and I don't know, I'm not convinced that's the posterior tibial. So what I'll do now is do two things. And notice how cautious we are in doing this. What I'll do now is have Dr. Guja inject from above and I'll inject from below once it starts to retrograde fill to see whether we can match the dots. So at this stage, we're going to wait. The guy's not cramping or anything like that, I hope. You know, which again, it's a common in these type of cases. So go ahead, Dr. Guja, inject. So Dr. Guja just injected up, he's cramping. No te mueva, señor. It's injecting from below, above. Don't move him, please. So we're going to wait. Oh, he moved, so he's cramping. So we're going to go ahead and have Ricky help him with the cramping. I can't do it from there. Ricky, can you come around and just reach underneath? So a lot of times you can see that there's a lot of extra movement and things like that going on. So, you know, when these patients cramp, we don't use anesthesia in these type of cases. Good, Ricky, thank you very much. So in these kind of cases, we don't use anesthesia. So now we're going to go ahead and again, señor, no te mueva, inject please. See, we're going to that collateral, Dr. Wiley. You see it?
I see.
So it's going to be a little tricky to see if we're in a collateral or we need to make a different type of move. So now we're going to switch our angle of the camera to the other side. Yep, I'm watching my knee. Yep. Sorry, my friend. Mejor?
So Prakash, you're doing dorsiflexion and plantiflexion to relieve the pain, correct?
Right here, right? Aquí. Yeah, sorry. Okay. Okay, so we're just going to go and inject one more time. And this time I'm going to see, center it. Higher. There you go. Good. You ready? Give me some, okay, let me inject from, so this way. Sandy? No injection. Okay. So remember, you have a lot of, what is it called, you know, AV fistulas which occur, which is not something to get really worried about. So now we're just going to look at this and analyze where we're at to decide which way to go. So I'm going to go back in here. Can I have the conference, guys?
It's hard to tell what is what here.
Huh?
It's hard to tell what is what here.
Well, it's a tough case.
Particular because of the AV fistulas, which are making it a little harder to identify what is what.
Well, remember, I'm actually inside the vessel here, so I'm inside the collateral. I could always pull back and inject.
So, Prakash, if you were to change your strategy and do retrograde access from the tibial vessels, at what time would you do that?
Dario again. What time will I do that, Dr. Wiley? Mm-hmm. We've basically decided that we're going to give this a good shot from above.
Okay.
And if we fail, we will convert this to a retrograde case since it's an ulcer. We'll probably give, obviously, we're limited by time, so hopefully we can do it on live. If not, we'll do it offline and show next week. But I think it's important to really show the principles of what we're doing. And I think it's also important not to always go to the retrograde approach, especially through the tibial. I believe that, you know, a lot of people are just, you know, very, very quickly transferring it, you know, immediately to the retrograde approach. And I think with a little bit of persistence and on hard work, you should be able to get through these without an issue.
I agree.
You know what? I need a torquer. You know what? Give me a PT graphics wire. So you can see here the different wires we're using. We tried with a fielder, which helped us, and now the really stiff 014 wire did not help us. So now we're going to go with another wire called which is another hydrophilic tipped wire with a nice stiff body, which is going to help us as well. So this wire is a wire that's actually quite good that we've used quite a bit in the coronaries. So that I'm going to switch to this. It's a little slippery and should be able to get through this. So we're going to try for another 5 minutes with different wires from above, and if not, we'll go ahead and stick below and come back from below. So we're just going to go ahead and go forward with this. Can you get a torque around this, guys? So, it's one of those things, Jose. Anything in your experience that you would try with this in this particular area?
No, I think I would do exactly what you're doing. I like to have a multi-purpose catheter and inject while I'm doing this, just to visualize a little bit better. But you have a good support catheter there. The choices of wires, I think, is very, very appropriate, starting with a fielder wire and then going up the ladder into stiffer wire. So at this stage, I don't think I would have done anything different.
Hold on.
You perhaps may want to use that support catheter a little, put it closer. Yeah, exactly. And that may help some.
Yeah, so I think, we're learning about the CTO as we go along here. So that's what I'm trying to figure out about the CTO.
Is there any collateral that you could use and do retrograde transcollateral?
Yeah, there is, Dr. Wiley. So there is a few. So it looks we're definitely through somewhere. The question is, where are we through? So, not to worry, we're somewhere. Let's go. Inject. That's enough. So it looks like we're pretty happy here, Dr. Wiley.
I think so too.
So,
you probably want to do another view, make sure that.
Well, I think you learn a lot from the movement of the wire, and I think that's what I'm going to do here. Obviously, just showing different techniques of what we're doing. So I'm going to have Dr. Guja to go to another view here. Actually, no, this view is pretty good. And I'm just going to try to push this down and really show the audience that we are in the, looks like we're in the posterior tibial artery there.
Looks like that.
So you see, so this is the different techniques of getting through. So now what I'm going to do, guys, is try to get this catheter through, right? So this catheter may not go or may go. See, it's not going. So no, he's just clearing his throat, guys. He's not in pain. So we're just trying to get, it's not going. So now now is the advantage of working in a 300 system, right? So what we're going to do is we're going to walk this out, and we're going to ask for we're going to change out this wire. So what I'm going to do is I'm going to go with another 014 coronary support catheter. Go ahead. Walk that out. So for sake of teaching, we're going to show you, always watch that distal wire prior to going. So we're going to watch that distal wire very, very carefully. So now, as Dr. Guja is taking this out, we're going to get an 014 support catheter and change that for a safe wire. So to recap, the important things to really think about are, number one, understanding the anatomy. If you do not understand the anatomy, you're never going to have a successful cross. Looking at this in one view showed you very, very simply that, oh my God, I've got all these collaterals coming. But when Dr. Guja and I sat down and showed you multiple different views, you're able to see that there may be channels. Now, can I be in a collateral? You know what? I don't think so. Very, very unlikely. But anything is possible. So, at this stage, have we gone transcollateral into and not in the true lumen? I doubt it. But, I guess anything is possible, Dr. Wiley, especially in these kind of cases.
Yeah, it seems to have moved quite smoothly.
I think
quite distal as well.
I think the whole charm of this case was identifying the path. Once you identify the path, you're able to get there. Can I have a dry gauze, please? It's slipping in my hand. So this is obviously a high catheter, which is a coronary CTO transcollateral that they actually use from transcollateral in the coronaries to go ahead and attack these lesions. Rail me, please. Am I past it or no? Okay, there it is. So you can see the transcollateral nature of this catheter is trying to help us get through. We're still not through here. You can see that it's still very, very tight. Show me down below, please. So I'm going to try to just, and see, this is where an antegrade approach may help you, with a little bit of more pushability than a retrograde approach. Ready? So what we're going to try to do is, again, try to be really aggressive. No die, guys. So this is not helping. So now what we're going to do, walk this out. So do what Dr. Guja suggested, which is go. So, wire? So watch the wire, guys. Don't get casual. So we're going to go. We're going to go with the balloon. Don't push the wire.
Would you consider laser at this stage where you cannot advance your?
And I think that's a great point. Can you push the wire forward, please? Hold on.
I mean, first have to ensure that we're truly in the posterior tibialis, but if that's the case, I know you used laser in the past for cases similar to this.
I think one of the things that we asked Ricardo to set up today was a laser when I spoke to them yesterday, and I don't think they have a laser ready in the room, you know. So we have it outside, so we might have to set it up. So before we do the option, if you can't get through these type of lesions, is to try one of these transport catheters or try a laser. So give me a 1.5 balloon, please, 1.5 coronary balloon. So we're going to use a very, very small balloon, maintaining our wire position at that level in order to break the channel. Can I have a 1.5 small balloon, please? So the options, once your wire's through, and I think this is much more of a common problem than occurs, is that how can you get your equipment down there? So one is you can try these transport catheters like we've done. So you can try an 018 catheter or an 014 catheter or an 014 transcollateral catheter like we just did, which happens to be the fine cross. So we tried what's called as a trailblazer and then what's called as a fine cross catheter to be able to try to get through. Now, since we cannot get through, the next option is to try a very, very small balloon. So we have a 1.58 balloon or 1.56. What's the size, guys? 1.58 balloon. So it's a 1.5 millimeter in length balloon. And what we're going to do is we're going to try to get this down there as well. Protect yourself with the shield, please. Protect this down there as well. So now we're just going to go ahead. No te muevas, señor. Todo bien. Yes, sir. So now I'm using an 014 balloon because it provides a little bit more pushability than an over-the-wire. I mean, there's always controversies in that. Some people feel an 035 balloon is more pushable. Some people feel that an 014 balloon is more pushable. And you can see, Dr. Wiley, it just doesn't want to go.
You jiggling it there? Or?
Well, you know, it just doesn't want to go at this level.
It's not going.
You know, so I think the issue just becomes is that the cap? And the other thing you could do is probably inflate at this level. Right, create a channel and then reduce some of the tension on the balloon.
Prakash, you want to take a picture,
okay, let's take a picture
of the wire distally to see if, just to ensure that we're truly in the PT?
Sure, we can take a picture for you. Yeah, I know. Inject. No, not this one. Show me at the level of the balloon. Okay, inject. We're going to need that laser, guys. See, we're truly in the PT, Dr. Wiley.
I don't see anything here.
Oh, I can see it clearly. Is it not showing for you?
Not yet.
Why is the picture so bad, guys? The picture is so bad.
I think you're in PT here. It's very grainy. I really can't visualize very well.
It's a terrible picture, guys. Can we help fix that, please? Yeah, you already dilated it.
Well, I guess I'll trust you.
Okay, down. Can we tell the AV team that it's just I can't see anything, Dr. Wiley, especially when I look up at the net side. I don't think the people outside are seeing anything either.
I'll let them know. They're with me here.
Nope.
So.
Okay. All right, guys, we're going to have to use the laser. Let's set up the laser here. Okay.
So what catheter are you going to be using? What laser?
We're going to use a 0.9, Dr. Wiley.
Okay.
To blast a hole through this. So I think this is where all the tools in the toolbox really come in handy. You can see here that we did this. Give me a 125 balloon, guys. 1258 or 128. So as we get the ready, I'm going to keep trying to open new balloons. And try it. Did we fix the AV connection, guys, with the picture? Because you couldn't see anything. It's kind of what happened in the symposium a few years ago. Completely whited out.
No, it's kind of grainy. He was able to see the vessel, but we weren't able to see it here.
No, but Jose, we couldn't see anything when we looked up at the main screen here.
You couldn't see it either?
It was the picture. You couldn't see anything.
Okay. let's see what we could do from this end. So you're setting up for the laser?
Yeah, we're setting up for the laser, and as they're setting up, give me the 1, 2, the smallest balloon, guys.
So, Prakash, assuming that you were in a lab that did not have laser, and you had already crossed with a wire, would you then consider access through the pedal and try to snare it?
I think you could, Dr. Wiley. I think the other point here is whether when you're doing this kind of work, I think you got to have certain equipment. I think a laser is not something that's out of this world to have available. You know, I think a laser is something that most labs should have, especially if you're doing complex below the knee cases such as this one.
But assuming you did not have one.
So if you did not have one, then I think you're really left with really no choice other than to go pedal.
Okay.
You know, the only other thing you can do is whether there's another support catheter that we may use that's quite a little bit more expense, which we may try next. It's called Corsair catheter, and that may be the next thing to try if this doesn't go before I open the laser. Because again, I really think that these are all just different ways of approaching this particular disease process, and let's see how this one goes. We know this is where it got stuck.
Prakash, I just got a question here. If you had to do pedal access, what would be your approach after crossing that lesion? I think they're referring to whether you're going to snare the wire and externalize it, or what would you do?
Well, I think the only thing you could really do is snare the wire and externalize it here, Dr. Wiley.
Okay.
I really do. Nope, you cannot go. Nope. Okay, get us the laser, guys. 0.9. So can we get that? Can we show them the laser setup, guys? So get me a venous bag, please. I got it. So go AP to check the place. So when you're doing this kind of pushing, you always want to go and check where whether your sheath has moved up or not, Dr. Wiley. So what Dr. Guja is going to do is while I set up the laser, we're going to go ahead and check. So you can see that the sheath has not moved.
Prakash, we're having problems seeing the screen.
Yeah, I know it's really
very grainy.
I can tell you right now that I can see that it's not a good. Right now we can't see anything.
Where's the tip of the crossover sheath?
Where's the tip of the what?
Of the crossover sheath.
It's at the level of the common femoral, just below it.
Okay, still there.
Okay.
Well, this case is becoming a little more complex than what we even thought, now having to use laser and all these devices.
I think that's the complexity, and also the complexity is that we're not able to see the AV for you guys. It's actually quite an exemplary case in terms of how to cross. So to answer your question right now, if you did not have a laser, you would probably have to get pedal access, come back up and over. Okay, cross the lesion, snare the vessel, snare the wire, and then externalize the wire, and then work. Okay. So here, I think the problem is we've been able to get up and over, we've been able to get across the lesion. The question is whether or not we can go ahead and do this. And part of that is, the laser has a little bit of a setup time. As you can see, we've got 2 minutes, 20 seconds, and we're waiting. So what Elizabeth is doing right now is she's setting up a venous flush bag. And it's important to remember that when you do laser, you want to have no dye in your field. Obviously the dye will cause some explosions. So what we do is we attach the laser next to, we attach the port, the saline flush, the side port of our sheath, and then allow it to flush through, liberally. Obviously, in this particular patient, you also have the ability to actually give him some fluids because of his creatinine issues as well. But the purpose is really to avoid any dye in that level. So it's very important that you actually are very, very certain that you have crossed into the true lumen before you do laser. Now, obviously, with laser, you're going to have the fluency and the rate. So when you plug the catheter in, it's going to come to a set fluency and the rate. So the key is just to keep going up on your fluency, and then try to break through this particular cap, which I've never failed with the laser yet. Although anything can happen. So we will take a look now as Dr. Guja flushes the port, ensuring that there is absolutely no dye within the vessel. What's the matter? No dye within the vessel. So we got less than a minute to go here. So we're gonna bring it all the way down to 0, and then it's like almost like a countdown of a NASA shuttle here.
So, Prakash, while you're getting ready, as you know, the pedal axis is becoming the new kid in the block, even though I'm not a big fan of that technique, although sometimes you have to utilize it. Do you mind running us through how do you approach it? Do you use a sheath? Do you go sheathless? Do you use what needle? Just the basics for the audience to understand.
Absolutely. And Dr. Guja will actually review that in our write-up if this is the one we're writing up for the Cardiosaurus Weekly newsletter. What we will do is so as far as pedal axis is concerned, I think there are two things that are essential. One is you have to have either ultrasound experience in using ultrasound to be able to identify the dorsalis pedis or the posterior tibial. Number two, what also happens is that you also need to know that the vein and the artery very much close to each other. So anyway, as we talk about it, let me just set up the laser here, Jose.
Yeah.
So what I've done is I've gotten the laser plugged in, the laser set, and now if I can have somebody's help so I don't drop this on the ground. Okay, thank you. Let's just straighten this out. And it's all twisted. It's one of those things here. So anyway, so what you want to do is go ahead and step on the pedal, and then go ahead and point the laser and calibrate it, which is what we're doing here, right? So we're just going to calibrate. Actually, hit calibrate, please. Calibrate. So we're calibrating the laser. So it's ready. So now we're going to go ahead and enter. Dr. Guja, obviously, get this out here now, please. Dr. Guja has obviously cleared up any of the dye out of our system. And now we're going to go forward. I'm having a lot of resistance, please, with my yes, thank you. So you can see it can get quite cumbersome, Dr. Wiley, with this kind of stuff here. So we've got a lot of equipment, you've got your radiation shield, et cetera. We're loading the laser onto the 014 wire. And we're going to go down and do our work here. Let me get one. Did you flush this in a lumen?
Yes.
Wet one, please. I'm having resistance. I'll flush this in a lumen, guys. So what you can do, Dr. Wiley, is just come with once you identify the artery, you can stick with an 014 needle and go and just enter it with a micropuncture needle. Once you enter the dorsalis pedis of the posterior tibial artery with a micropuncture needle, what you can do, hold on, let me just wipe this wire down. What you can do is advance the wire all the way up. Go ahead, pull. Okay, now rail, Flora.
With a sheet, without a sheet, through a dilator, or what?
You definitely don't want a sheath. You definitely don't want a sheath in that particular vessel. Watch the wires moving down. Rail, please. So you definitely do not want a sheath there, Dr. Wiley.
Do you want to put a dilator?
You don't want. I don't even put a dilator. What I do is, initially I put a dilator. Okay, guys, rail, please. And then through the dilator, show me above, Ray. Through the dilator, I go ahead. Okay, guys, I need a rail. I don't want the wire to go distal. Okay. Okay, good. Now we're there. Okay, let's start lasing, guys. Okay, ready? Go to on-treat. Ready? Go. Flora. Ready. Hit ready. Okay. All right, so we're having a little technical issue here, Jose, with the calibration of the laser. So you got to take it out again and calibrate it again. Take it out again. So what you want to do now is just go ahead and calibrate the laser. And I apologize for this. Obviously, there's things that we do not control with these machines, and obviously it needs to be calibrated one more time.
That's okay.
So we're going to go ahead, calibrate it one more time, and go ahead one more time. Okay, good. Can you get me a Corsair, somebody? Let me try with that. So obviously we're again running short of time with these complex cases. So we're gonna try to do as much as we can.
I'm glad it's become a more of a complex case than we had expected, because the audience
but I
in seeing
think
how you get out of Dodge.
But I honestly think it was a complex case to begin with, Dr. Wiley. Ready? Okay, let's try again. Because one of those things I think is that everybody gets fooled with this stuff. Okay. What happened? It says calibration okay. Yeah. No, it's ready. It's ready. It's ready. No, it's ready. So we'll go one more time. Don't open that, Rick.
So you're still on your 014 wire.
Yep.
Okay.
Okay, rail. Come. Okay, rail.
Where's the tip of the wire?
I don't know. That's one of the things that's very important. Like you said, Dr. Wiley, show me the tip of the wire, please. There it is, right there.
Okay.
Rail, please. It's moving again. Okay, guys, let's start. Yep. Flora. You can see it's moving so fast.
Yep.
Pull it back. Nope. Okay, off. What is your fluency? Go up on your fluency. Go up on your fluency, please. Go up on your fluency, please. Go to 60. Oh, that's fine. Increase your rate to 30. That's fine.
So you started at what fluency and what rate?
The standard, Flora. Go.
And 25, Dr. Wiley.
Okay, walk it back. Okay, off, Ray. Okay, Flora. Give me the pedal, guys, so I can control the laser. So you can see, Dr. Wiley, this is a lot tougher than we expected.
I know, but
so and it's showing
moving.
you all the challenges that you can get. Go, Flora, please. Okay, I'm going again.
I think you're making headways slowly, but I think it's moving.
It's extremely tough. Walk it back.
So what fluency and rate are you right now?
We're at 45 and 30.
Okay.
Off. 55 and 30. Go to 6. Go to the max here, guys. Go to the max fluency first before you go up on the rate. 80, I think it is. 80 is. 80? Yep. 80. No, just leave it there. Go. Go. Go, guys. Flora, please. What happened now? All right, walk this out.
Are you a fan of the explosions and injecting some contrast and then putting the laser on, even though it's not a label for that?
We're having quite a lot of technical faults here, Dr. Wiley. Give me the Corsair now. Let me try with that. One of the things that we have not expected to happen is this kind of stuff. It usually works very, very well. And we're having these problems with this laser for whatever reason. So we're using the 0.9, which is the smallest laser, to actually work on these kind of channels, and it usually works quite well. Okay, so I'm just going to keep working while these guys are working with another catheter, a very slippery catheter, see whether this helps to try to get through. So I think this might be one of those that we're going to have to come back and show, Dr. Wiley. It looks to me that we're not going to be able to get through within the hour.
You know, it may have been that now with the other crossing catheter, it may go through.
Okay, rail? Mm-hmm. Rail, guys, for me. Oh my God, so we lost the wire now. Which is something that I cannot tolerate, but that's what happened. Walk this out, please. Okay, look out.
Advance the wire and see where. That's the problem.
Jesus Christ. Show me down, please.
I think you got to pull back even more.
Yeah, you know, the problem is we're not able to torque this wire now because of we lost a lot of the body on this wire. Can you show me above, please? You know, this is just so. Oh. All right.
See if you could cross it with the other catheter and then exchange it.
Well, I'd like to.
I think you may be able to do so. What catheter do you have in hand?
The crosshair, Dr. Wiley.
Okay. Yeah, let's try it.
Yeah, but we're going into a collateral, so what's the use? Rail, please.
Perhaps pull him back somewhat and see if it goes through.
Well, let's just we can break through some of the cap.
Yeah.
It's just you know, something that happens that really should not be happening to anyone. You know, let go, please. Let me show me above.
Happens to everyone.
Yep, happens to everyone. So this is where this got stuck. Give me a torquer here, please. Let me try.
No, I think you gone forward.
I did go forward,
yes.
But I just need to not try to torque it. This is a catheter that you can use sometimes.
So what other wire would you use?
Well, I just like to get into the true lumen here, Dr. Wiley, like we were before. I'm going to a collateral now, which is really bothered there. Oh, there it is. Follow it down, guys. Follow it down, guys.
You're in the right place.
Okay, good. Okay, now let's see what I can just break through slowly. Just got to go a little bit more. Let me just try to screw this. Try to. Okay, let me try again. So I can look up. Just let go, please. Give me a dry gauze, guys, here. So what I'm trying to do here, Dr. Wiley, is just create some torque in this catheter and try to get it through. That's fine. The wire's fine. Nope. It's just that final bit that's not going. What we can also try to do is now change out for a stiffer wire.
Yeah.
So give me a command wire here, guys. Rail. Nope, does not want to go. Walk it out. Walk this out. No, leave that there. No, let me see. Actually, the crosshair, this has gone further than the razor catheter went. So, all right, let's go roadmap here. Stop. Roadmap, please. Inject. Enough. Got a long way to go, Dr. Wiley.
You know, I'm pretty certain that the wire is in the PT, so it may be time, if you cannot cross, to get a pedal access, externalize a wire, have a stiff rail, and then hopefully getting this catheter to cross.
Push the wire down, please. Yep, nope, it's not going. Okay, let's give me the command wire. Take this wire out. Pick it up. I think that's what we're going to do. We're working here at this stage now, and what I think we're going to do is try a little stiffer wire here, and then see whether we can go ahead and internalize it, and then if this does not work, we'll go ahead and do the pedal access. So for the sake of time, let me just conclude this. I mean, I know that, you know, obviously once we get this through, I mean, our treatment strategy is either going to be atherectomy or balloon angioplasty. Can you move this, please? Atherectomy or balloon angioplasty or something like that. So at this stage, I mean, let me just conclude with what we've been doing. You know, obviously what we did was we went ahead, the important teaching points are very simple. One is you want to make sure that you identify what are the vessels, and you want to identify the differences between the vessels and the collateral channels. So the important way of doing that is to go ahead and take a look at multiple different views of the particular lesion that you're looking at and identify whether any other channels exist. If any other channels exist, that obviously will help you, like we did in this particular case, to find the true channel and then cross the lesion. Once you cross the lesion, the problem can sometimes start, like it did in this particular case. So what happened in this particular case? So what happened in this particular case was that we kept getting into come down. We kept getting into trouble crossing the lesion. So right now we're struggling, even though the wire is so smooth, going across to cross this lesion. Now we tried the laser, which we're probably going to end up going back to. Walk this back a little bit, please. And now we're trying a stiffer wire here, and with the hope that it gives us a little more support, which it's trying to, but not quite. Walk this back, please. So now what I'm going to do is I'm going to ask for a 2-0 balloon, actually another 1-2 balloon. Another 1-2 balloon. So the options to cross these difficult lesions once the wires are crossed is obviously a laser. You can use a support catheter such as what we've used right here, the Crosshair, the Fine Cross, or the 018 Trailblazer. Or if that doesn't work, you can do a retrograde approach through the pedal access, and then come back up and snare the wire, which is what we're probably going to end up doing here.
Yeah, I think you're going to have to externalize both sides of the wire and have a very stiff rail, and then.
Yep. So what we'll do for the audience now is we'll go ahead. We'll obviously stop. We're 5 minutes past our time, and what we'll do is you go ahead and do a recap for the audience regarding this our procedure and what are the teaching points from access to anticoagulation and different techniques. And then what we'll do is next month when we come back the day before Thanksgiving, we will go ahead and show them what we did to get through this.
Excellent. Good job, Prakash. This is a very challenging and difficult case.
It's still not done, Dr. Wiley. I mean, obviously you're doing multiple things at once, and this is definitely one of those cases that requires a lot of attention and a lot of effort. I thank Elizabeth and Karthik and Surabhi and all of our people, Ray and Ricky in our lab and the AV team for helping out. And I think we'll sign off here. See you next week. Next month, I mean.
Thank you very much, Prakash.